Hello and welcome to this neuro-ophthalmology talk about the review of ischemic optic neuropathy. So to get started, we'll just do the normal disclaimer. And what that's talking about is saying this is just for education and for thinking about purposes. It's not for diagnosing or treating any diseases. If you do have any sort of problem or need help with the diagnosis, make sure to see a qualified physician or some sort of other healthcare professional instead of this online video. All right, so moving on. Just as for general definition purposes, we're talking about ischemia, and ischemia goes under the big term of hypoxia. It means you're not getting enough oxygen to the tissue. Ischemia is referring specifically to a problem with not enough blood supply to get the oxygen there, as opposed to hypoxemia, saying there's not enough oxygen in the blood. So the roadmap, or the way we're going to approach this, because I think this is kind of a tricky topic, and there's lots of different definitions and sort of acronyms. And we're going to approach it by dividing it up into an anterior and posterior ischemic optic neuropathy. And that division is made based essentially by blood supply to the different parts of the optic nerve. So you have the anterior part, which is like the optic nerve head and choroid, which gets supplied by arteries called the posterior ciliary arteries, and we're going to talk about this more later. And that's the anterior part, anterior ischemic optic neuropathy. And posterior is sort of the rest of the optic nerve behind there. So once you make that division, which is based on blood supply, which dictates which part of the optic nerve you're talking about, the second division is made in each group based on whether it's arteritic or non-arteritic. And arteritic is referring to a vasculitis. Non-arteritic is saying it's not a vasculitis, it's something else. And then so you can see here there's a lot of sort of abbreviations. And how it works is you write, so if you're talking about anterior ischemic optic neuropathy, A-AION, and then in front of that you can either put like an A, saying it's arteritic, or NA, non-arteritic. Okay, and you can do the same thing with posterior ischemic optic neuropathy, so PION. You can either put an NA or an NA in front of it. It's the same sort of idea. And then the posterior ischemic optic neuropathy has this third little subject called surgical, PION. All right, so I think just from the roadmap talking about it, it's kind of clear that you need to understand what is the difference between anterior and posterior when you're talking about these ischemic optic neuropathies to sort of really get what's going on. So we'll talk about that next. So to do that, we need to talk about the optic nerve and how it looks like when the optic nerve is sort of coming out and branching out there. So we'll divide this up into several different portions. So the first one is the retinal nerve layer, which is just up here. So that's really not part of the optic nerve head per se. It's just the retinal nerves. You have the ganglion cells there sending out their axons, making up the optic nerve. And then behind the retinal nerve cell layer, you have this pre-laminar region here. Then you have lamina cribrosa, and then behind that you have retrolaminar region of the optic nerve head. And so this is the part of the optic nerve that we're talking about, and the blood supply, which makes it the anterior ischemic optic neuropathy, is coming from arteries called posterior ciliary arteries. These are branches off the ophthalmic artery that usually come off after the central retinal artery, and there can be different numbers of them, 2 up to I think 6 or 8, and it also can vary between individuals and between eyes in the same individual. So these arteries are different than the central retinal artery, which kind of goes here at the end and travels within the optic nerve. These arteries are coming here on the outside. They travel up. They give off lots of little branches supplying the optic nerve head. They come in on both sides, and then they go up and supply the choroid with blood. All right, so these are the posterior ciliary arteries which supply the optic nerve head and are dysfunctional when you have anterior ischemic optic neuropathy. And when you're talking about posterior ischemic optic neuropathy, we're talking about ischemia to the optic nerve from loss of blood supply, not to the posterior ciliary arteries, but to other branches of the ophthalmic artery which supply blood to the optic nerve behind the optic nerve head, posterior to the optic nerve head. All right, so that's the general breakdown of anterior and posterior when we're talking about ischemic optic neuropathy. Now, from the last slide, we sort of hinted at this, that the eye doesn't really have like one artery and one vein that supply it. That's not the way the circulation of the eye is divided up. It's really divided up as into two different types of circulation. There's a choroidal circulation, and there's like a retinal circulation. And when you have a central retinal artery occlusion, one of the findings is you see this cherry red spot, and that's kind of an example of showing the differences between the circulation. I think we're going to draw it out here on on a whiteboard to try to see how it works. So you see we have an optic nerve. We'll just show that there generally. And then we'll have, there's the ganglion cells with their cell bodies producing their axons are there. So we'll just imagine that this, this obviously goes up and makes the retina, the back of the eye. And then beneath that you have choroid. Right? So when you think about the circulation of the eye, you think about it twofold. So one is you have a central retinal artery, is also a central retinal vein, and central retinal artery branches off of the ophthalmic artery. It's the first branch of the ophthalmic artery. It travels down, comes into the optic nerve, comes out, passes through the optic nerve head. It doesn't give off branches in the optic nerve head. It just passes through and then divides out and travels here in the ganglion cell retinal nerve fiber layer up here with the retinal nerve fibers. And this is what you see when you're looking through the ophthalmoscope. You see arteries and veins coming out. You're seeing the central retinal artery and the veins sort of shooting out through the optic nerve head, and they supply the blood with the retinal ganglion cells on both sides. So that's the one sort of circulation. And this, you can think about it as supplying the blood to the outer 2/3 of the retina. That's not the only circulation. We also were talking about the choroidal circulation and the posterior ciliary arteries. So we know that there's other arteries which also branch off the ophthalmic artery after the central retinal artery, or they can even come off sort of like a common trunk or come off the central retinal artery. And these are the posterior ciliary arteries. They come down and they make these little branches around the optic nerve head, and they supply the choroid. Okay, little branches into the optic nerve head, and then they also supply the choroid. And you can think about that as supplying the blood to the outer third of the retina. And so in the sort of the back part of the retina, one of the important structures you have there that need lots of good blood supply are the photoreceptor cells. So you can imagine if you lose blood supply to the posterior ciliary artery, it's going to supply blood to the choroid. It does this in a segmental sort of fashion. You'll lose blood supply to the choroid, then the overlying photoreceptor cells won't have enough blood supply and will die off, and you'll have problems primarily being visual field defects. And what I was talking about before with the central retinal artery occlusion as a way to remember what happens when you have a central retinal artery occlusion. What do you do? You lose a central retinal artery, and then so you get some pacification of, when you look at the fundoscopic exam, you look and you see pacification, pacification of most of the retina, but then there's the cherry red spot over where the fovea is, because the retina there is thinned out and doesn't have the blood vessels overlying it, and so what you're seeing is the underlying choroid, which still typically would be getting a normal blood supply, because the eye has two different blood supplies, this choroidal supply as well as the central retinal artery type of supply. Alright, so I think that's enough about that, and we'll move on. Just go over the ophthalmic artery a little bit. So, the ophthalmic artery, we know that it's the first branch off the internal carotid artery. The ophthalmic artery passes through the optic canal with the optic nerve, makes a sharp right-hand turn, runs along the medial wall of the orbit, and then it gives off a bunch of different branches. And the way to divide up the branches of the ophthalmic artery is into two different categories. So you can think about it as an orbital group, which these are the structures sort of around the eye. For example, there's an ethmoidal artery, a supraorbital artery, a lacrimal artery, so supplying the blood to the structures near the eye. And then there's also an ocular group. So the ocular group supplies the blood to the globe in the orbit. So the posterior ciliary arteries, the central retinal arteries, these are kind of part of the ocular group. And the central retinal arteries we talked about is the first branch off the ophthalmic artery. Alright, so for a quiz style thing, just as by way of review, can you picture in your head the way you get to the ophthalmic artery? So what happens? So you can imagine the aorta kind of making its arch, something on the left, something on the right. How do you get there? So I'll give you a chance to think about it on the right and the left, and then we'll see the answer in the next slide. Alright, so let's head over to the next slide, see if we can figure out how to get there. So you're coming up. On the right side, you're going to break off into the brachiocephalic, the subclavian, and then we have the carotids, and we know that the carotids divide up into the internal and external, right? ICA and off of the ICA we talked about comes the ophthalmic. Then the left side we have the common carotid coming off its own trunk and doing the same division. Then you have the subclavian as the third major branch there off the aorta. All right. An important note about where the ophthalmic artery branches off the internal carotid artery is that this typically happens when you pass through the cavernous sinus. This is kind of an important structure and will be talked about in a subsequent lecture that maybe we can link to this one. But that's where the branching off usually occurs. All right, so I think we've reviewed the anatomy a little bit here. So we know that there's an anterior ischemic optic neuropathy with blood supply from these posterior ciliary arteries, which can vary in number from like 2 to maybe 6 up to 8. And they come off the ophthalmic artery usually after the central retinal artery, but sometimes with it as well. And this posterior ciliary artery circulation is what's dysfunctional in that. Then we know that the posterior ischemic optic neuropathy is when you're behind the optic nerve head and you have a different blood supply than the PCA, which is it's called a peel circulation, and there are different branches of the ophthalmic artery. And you can imagine the optic nerve traveling here, and it has it's part of the CNS, right? So it has a peel layer, and there's just different little collaterals coming off of the ophthalmic artery that supply make a vascular plexus there that supply the blood supply to the posterior part of the optic nerve. All right, so if we're thinking about the optic nerve in its different layers, you have the surface nerve fiber layer. What's that supplied by? That's not the PCA circulation, that's the retinal artery circulation. So that's like the branches of the central retinal artery fan out and supply blood supply to the nerve fiber layer. Then we have this laminar and lamina cribrosa optic nerve head area. That area is supplied primarily by the PCA circulation. And then you have the posterior part, so you're behind the retrolaminar region. What's that mostly supplied by? That's mostly supplied by branches off the ophthalmic artery that aren't the posterior ciliary arteries. It's supplied by this peel circulation. All right. So now we'll kind of move into the meat of the topic. With that framework in mind, we have a good idea about how the blood travels, how it gets to these different parts, and how it can kind of be dysfunctional. So we're going to start with non-arteritic ischemic optic neuropathy because this is the most common. So it's more common than arteritic ischemic optic neuropathy. And so what's going on when you have non-arteritic ischemic optic neuropathies, you have an acute ischemia to the optic nerve head. So you have a problem with blood supply in the posterior ciliary arteries. There's two different ways this can happen. There's one way this is like a transient hypoperfusion. You can't auto-regulate anymore. The blood pressure is too low and you lose enough blood supply that way to get ischemia. Or you can have embolic lesions which block off some or more of the posterior ciliary arteries. The important points here are that, one, you can think of the hypoperfusion, or at least I think about it as the way you can have this in lots of different parts of the body, right? Like someone who's hypotensive, maybe in an intensive care unit, they can have mesenteric ischemia from hypoperfusion, or you can have someone with these, so-called type 2 NSTEMI. It's demand-induced. They can't perfuse their heart well enough, and they have a little bit of ischemic damage. So that's kind of the way I think about the vast majority of non-arteritic ischemic optic neuropathy. It's like a hypoperfusion type of problem, and the minority being like embolic type lesions. All right, and so you have this clinical condition. So you want to think about who you should look at this in and what are the risk factors for developing this. So there's a way to think about it, which you can divide it up into the systemic risk factors, which are primarily all the typical vascular things that you would think of: hypertension, diabetes, if they have peripheral vascular disease, ischemic heart disease, all those sorts of things. And then the big one you want to add to that is what are the things that predispose someone to hypotension. Okay, so you have a gentleman coming into your office, he's, let's say, kind of elderly, like 70, he's on 3 different antihypertensive medicines. He just got started on amlodipine, and you found, he's having a problem with erectile dysfunction, and his PCP put him on Viagra, and he takes all these things at 10 at night. You can imagine this person might have some hypotension overnight. They might have some hypoperfusion of the optic nerve head and wake up with non-arteritic ischemic optic neuropathy. All right. So then you move on to the ocular and optic nerve head risk factors. So I think to understand the one of the risk factors, which is ocular hypertension. You have to understand a little bit about the how blood flow and pressure work in the optic nerve, which is the same as it is everywhere, but this is the way I do it. So you have like V equals IR, right? That's like your basic way to think about it. You have a change in voltage or pressure, right? And then you have flow, and then you have resistance. So that's the kind of the basic formula that you can use to think about it. And so if you're going to get flow, it's going to be we're just going to have it here. So if you're going to have the flow across the vessels, then the formula would just rearrange to the change in the pressure over the resistance, right? So let's say resistance isn't really changing that much. We'll just kind of focus on the perfusion pressure. All right, so the perfusion pressure of the eye, the delta P part, is going to be the map. And for map, at least what I use is diastolic plus 1/3 of the systolic, and then you're going to minus the IOP from that and get the perfusion pressure. So the point of going over this is essentially just to say that if you have a cause of ocular hypertension, so intraoperatively if something happens and the pressure goes way up, or maybe they have acute angle closure glaucoma, what's going to happen to this system will be the IOP will go way up, right? So you can imagine that's going to take a big chunk out of the map, and maybe the map is already kind of low, so then the change in the pressure to perfuse the eye will be really low. There won't be much perfusion pressure at all. Then you won't have a lot of flow, and you can get ischemia. That's all that is really to say. Just those little equations that can help you kind of remember it if you like it. I like the VIR thing. Personally, it just helps me remember. All right. So the second ocular risk factor that we'll just briefly go over is the so-called disc at risk, and it's a term that describes finding that people noticed that when you have people with non-arteritic ischemic optic neuropathy, they tend to have smaller absent cups. It's something that was noticed, and then they think about, then the thought was, well, why does this happen? And I think the idea is you have a lot of axons passing through a smaller place, and then so all these axons going through a small cup, they're maybe the same number as in everybody else, they're just passing through a smaller place, so it's like a tighter squeeze. And what you have with regards to the pathophysiology of what's going on with this disease is you have low flow, then you have ischemia, you have decreased in the axonal, you have axonal transmission going on, sending things up and down these nerves. And then when you have that, you have edema or swelling of the nerves, so they all start pushing against each other. And when you're confined to a small place around the optic nerve head, you're more risk to get into the cycle of so ischemia, causing problems with this axonal transport, causing edema, squishing more nerves, and causing sort of like a vicious cycle almost to happen. So I think that's one way to think about it, at least, and remember the disc at risk idea, that if you have a smaller absent cups then you tend to have more chance of having non-arteritic ischemic optic neuropathy. All right, and so moving on to more clinical-oriented type of things, what do you see, and how do you pick up on this? So somebody's going to have painless. Sorry, I repeat that again. Painless. There's no pain generally. Monocular vision loss, and they'll usually notice it when they first wake up in the morning, or often notice it when they first wake up in the morning. And to remember that, just think of the old guy taking all his blood pressure medicines and a bunch of Viagra at 10 at night, right? High risk of hypotension, might wake up, might wake up and notice this visual dysfunction. It's generally rare for it to be bilateral. It's also important to mention that the visual field defect is typically the rule, and acuity can be normal. And I think based on what we learned about how the blood supply works, you kind of supply part of the optic nerve head and a certain part of choroid. It kind of makes sense that you're more likely to knock out part of the visual fields than to decrease your visual acuity, which primarily comes from a very small part of the retina. Right. The most common defects that you see, and remember defects are the rule to be found, so you should find a visual field defect, are relative inferior altitudinal defects and absolute inferior nasal defects. And as a side note about testing for visual field defects, there's the two types of tests, the Goldman and the Humphrey, and this is one where the Goldman might be preferred because this is the manual one with um, the little balls moving in, and then you get the squiggly lines depending on the size of the ball used. So this is the test that's recommended for this because it tests a much wider visual field than does the Humphrey, the automatic version. All right, the natural history of this, in terms of what can happen, it can worsen or it can improve, and you kind of keep following it up to see how it's going. You can look up other resources to get sort of more details about that. Some of the characteristic findings when you're doing an exam, things that you can look for, are an afferent pupillary defect. That makes sense because it's an optic neuropathy. And the disc will usually show edema. Remember, the axonal transport is dysfunctional because of the ischemia, and the axons start to swell, which can then turn into pallor. Don't forget that even though it is a minority, there is some non-arteritic ischemic optic neuropathy caused by embolism and occlusion, and then you can see a chalky white appearance there on the disc. And then the typical FA findings, and this again will depend on what type it is. Is it the hypoperfusion type, which you see a delayed fluorescein angiography filling, or is it the occlusion type, which if it's the occlusion type from an embolus, then you wouldn't see any sort of filling over a certain distribution of a PCA. These typically happen on one eye, but given that a lot of the risk factors are systemic and things like that, it's more likely if you have one eye that you eventually will have both eyes involved. Typically, it's one eye on initial presentation. And then, the unfortunate thing is, with regards to the therapy, is it seems like there's really not a whole lot you can do about it. So that there's some investigation of maybe using steroids, but the idea that anticoagulation or aspirin are going to be all that helpful, I don't think is very well supported, at least, and that kind of makes sense given that most of the time this isn't like thromboembolic sort of disease. And so I think there's a little bit of this note here about controversy in the bottom. I think it's a little bit controversial about sort of the etiology and pathophysiology of this. The source I used made sense to me, and that's how I've presented it. But I've seen some textbooks kind of refer to this as an occlusive process, and it's not I don't think it's necessarily occlusive the majority of the time. And maybe if people know more about that, it'd be great if you left some comments. All right. And again, so therapy is no specific therapy. You try to reduce the risk factors of nocturnal hypotension or any other sort of vasculopathic risk factor that they have to prevent progression or development of this in the fellow eye. All right. So now we're moving on to the other big topic here, which is arteritic anterior ischemic optic neuropathy. So we're talking about the same blood supply, the posterior ciliary arteries, but now we're talking about a different etiology of the dysfunction here. So it's not either a hypotensive or embolic thing, it's a vasculitis. And so it's just used usually synonymously with giant cell arteritis, and, sort of most commonly, but it's supposed to be kind of a general term, meaning like, so you have a vasculitis that's causing the blood not to be able to flow through the posterior ciliary arteries, and then you get ischemia. All right. So this disease has a special predilection for involving the PCAs, and then you get ischemia and infarction of the optic nerve head, and it's usually a massive visual loss. It's a disease of the elderly. It's either is primarily been studied in or is most commonly occurs in Caucasian populations, although there's reports of it occurring in pretty much every racial and ethnic group. So to get this on your radar, and when you should start thinking about it, you can divide up the signs and symptoms into twofold, kind of like what we did before. So there's the systemic stuff, and I think we're all probably familiar with the idea of polymyalgia rheumatica as being a thing to look for. So that's like short shoulder, sort of girdle pain, also jaw claudication, and then type B type symptoms like they're feeling sick, they're anorexic, they don't want to eat, they have a general feeling of malaise, they may have lost weight. And then there's the scalp tenderness. You can feel for a pulse in the scalp. You can also have people with a headache. It probably should be on the differential of headaches, especially if it really localizes to a temporal area. And then you have the visual symptoms. So the big tip off would be if somebody has sudden, painless, severe visual loss, then you really have to think a lot about this. But it's important to note, and a statistic I wanted to add was that 20%, at least in some series, up to 20% of people have been 20 or 40 or better. So you can't say that, hey, the vision's pretty good or it's near their baseline. We're not having giant cell arteritis or anterior ischemic optic neuropathy going on here. You can also get extraocular movement or muscle disorders in the eye, because you get ischemia of some of those supplies to the rectus muscles and the muscles that move the eyeball as well. So you can have some signs of that. All right, when you examine the disc, usually you see a sort of a chalky white appearance, and then it can cup. Then you can get some cupping later on. And the two sort of special notes are the central retinal artery occlusion and cilio-retinal artery occlusion. So you'll notice in this talk about ischemic optic neuropathy, we didn't talk about like central retinal artery occlusion or branch retinal artery occlusion, because those are kind of the way that I think ophthalmology traditionally like organized or thought about, is those are kind of like retinal vascular diseases, and they're usually in a different part of the textbook or chapter, as opposed to the ischemic optic neuropathies, which are more of like a neuro-ophthalmology topic. Although, if you think about it, it's kind of all the nerve supply that makes up the optic nerve, and the etiology is problems with blood flow. But that's just how it's traditionally divided up. So that's why we're not talking about things like central retinal artery occlusion or related topics here. But the side note about it here is that if you see central retinal artery occlusion, then you have to think about giant cell arteritis, because the central retinal artery it can come off the ophthalmic artery. It can be part of the common trunk with the PCA. So if you see that you've knocked off the central retinal artery, you have to think about giant cell arteritis as the etiology, and kind of at least work it up or rule it out. And then the cilio-retinal artery is another thing that you can think about. And so the cilio-retinal artery is present in about 20% of people, and the way I think about it is it's part of the posterior ciliary artery circulation. So it comes off of the PCA, but instead of supplying the choroid and the photoreceptors like normal, it travels up to the retina, and what it does is supplies part of the macula and the papillomaculary bundle. And so the point of mentioning it here is if you saw a cilio-retinal artery occlusion, then you would want to associate that with saying, hey, that's part of the posterior ciliary artery circulation. I need to think about giant cell arteritis here as well. All right, now I'll go on again onto the kind of clinical type stuff. So what you want to work up with in terms of labs is ESR and CRP. Those two, when elevated, together are pretty sensitive for giant cell arteritis or anterior ischemic optic neuropathy. And then you can also look for secondary things like anemia, thrombocytosis, leukocytosis, which can be associated with it as well. And then temporal artery biopsy is the gold standard diagnosis for this. You get the biopsy on one side. You need to get like a large amount, chop it up, and try to see if you can see any arteritis in any part of it. And then even if that's negative, and if you have really high clinical suspicion, then you can get the temporal artery biopsy on the other side, because up to 9% of patients who have a negative initial temporal artery biopsy but a really high clinical suspicion end up having the diagnosis confirmed when you biopsy the other side. All right, and then so management, and the first thing that you should say about management is this should be thought of as an ophthalmic emergency, because I've seen this happen. I haven't really been doing this very long. I did ophthalmology as a student for like 6 weeks, and now I'm trying to learn a little bit more about it now. But I've seen this happen to people where they come in, the steroids get delayed, and then a healthy, totally functional person becomes essentially blind, or light perception and hand motion in the other eye in a really rapid amount of time. So the management is real key that you go and use steroids, use a gram a day, and you can do it as like IV methylprednisolone. At least that's the standard that I'd heard of as what you start off with. And the second point is that the duration of treatment, you should consider long-term high-dose steroids, and then taper off with clinical improvement, and then taper off when you see normalization of ESR and CRP, sort of as allowed by the ESR and CRP levels. So serial measurements of that with long-term high doses of steroids, and there's no set end point. It's not like you can do this for 4 weeks or 6 weeks or 6 months. You kind of do it based on the response to the ESR, CRP in the patient. And then again, it's just thought of as an ophthalmic emergency. You don't just start low or slow or think about it. You really need to assess all the things we've talked about and then give steroids or not give steroids. All right, so that's the end of sort of the anterior or ischemic optic neuropathy part, and then we'll go on to the posterior ischemic optic neuropathy part. And so just to start off with, posterior ischemic optic neuropathy as a whole is quite a bit less common than anterior ischemic optic neuropathy. So now we're talking about the anatomic region posterior to the optic nerve head. So it's behind the retrolaminar type region. This can be divided up into different parts: the posterior optic nerve, intraorbital, intracanalicular, intracranial parts of the optic nerve. And then it's not supplied by these posterior ciliary arteries. It gets blood supply from the pia, layer of pia around it, which has a peripheral. It's called a peripheral centripetal system of blood supply there, and it's mostly from lots of different branches off the ophthalmic artery. Also, some branches of the central retinal artery make contributions as well. All right, and so there's 3 different general types of posterior ischemic optic neuropathy. The first one being an arteritic one, so it's an arteritis, but instead of involving those PCA branches that we were talking about before, like with giant cell, it involves branches of the ophthalmic artery that supply the more posterior part of the optic nerve, cause ischemia that way. Then you can have non-arteritic posterior ischemic optic neuropathy. You can think about that in the same way that you would anterior ischemic optic neuropathy. Then you can have the surgical type, as you have someone that has surgery, they have massive bilateral vision loss. So when they wake up from surgery, they think it could be caused by profound hypotension during the surgery. Demographics are real similar, so it's middle-aged, elderly people. The arteritic version of posterior ischemic optic neuropathy also has a female predilection, as does the anterior the arteritic anterior ischemic optic neuropathy, which I think I forgot to mention earlier, but there is a female predilection for that as well. The visual acuity has a wide range and isn't a good way to either sort of rule this in or rule it out. And in general, posterior ischemic optic neuropathy is a diagnosis of exclusion. It's not something that you jump to. It's after you've ruled out other things. The visual field defects are different than what you'd see in the anterior ischemic optic neuropathy. And this gets back to a little bit of the way the blood supply goes. So you have the nerve here and then surrounded by pia, and there's some blood supply, and the pia kind of going in like this. When you have posterior ischemic optic neuropathy, you tend to have central vision loss. That tends to be more common. It's because the nerve fibers rearrange as they go posteriorly in the optic nerve, and there's only supplied by this peripheral sort of vascular layer, so the center area is a little bit more susceptible to ischemic damage. At least that's my understanding of why you have these more central visual field loss being more common when you have a posterior ischemic optic neuropathy. All right, and so when you're evaluating this, part of the reason why it's a diagnosis of exclusion and hard to figure out is that there initially aren't any abnormalities that you see. So you don't. This includes fluorescein angiography or FA type of testing. You don't see any sort of defects there, and later on, like weeks later, you can develop pallor. What you do find, or what you can find, is with optic neuropathy in general, is you can find an afferent pupillary defect, and then the exam being otherwise normal. And that could kind of clue you into this, to having this be what's going on. All right. So the management, just think about it as you would with the anterior version of these diseases. So if it's a non-arteritic posterior ischemic optic neuropathy, what do you think about with management? You go into like trying to modify vascular risk factors, trying to modify if the patient could be developing some hypotension, especially like nocturnal hypotension. Then if you have arteritic ischemic optic neuropathy, posterior ischemic optic neuropathy, you need to work up giant cell arteritis, and go from there. And the surgical the version of the surgical posterior ischemic optic neuropathy is generally thought to be you kind of can't really do anything about it, and you're unlikely to sort of recover any visual function after you suffer from that. So we've talked about this, how's the diagnosis of exclusion, how the management. You just go by the anterior version of the disease to guide your management. And then just to reiterate on ophthalmic, so when you evaluate, what do you see? Afferent pupillary defect, at least initially, and everything else being pretty much normal, including fluorescein angiography. All right, and this, like I've been trying to do in these talks, is put on my favorite resource for talking about this, and this is an article by this doctor here, and I think it's a really good summary, and it goes into more depth and details about the things that I've talked about. I think it's a great review. All right, as usual, thanks a lot for watching. Consider visiting the website for more. We try to have more resources there, PowerPoint, images, and things like that, and this is a free course. And also, if you've enjoyed this or been getting stuff out of it, consider going to 50kids.org and making a donation, or also consider going to the Aaron Michael BoundFoundation.org website and making a donation there. So, thanks a lot for watching, and take it easy.